Thank you for joining us this fine evening. Looking forward to this excellent presentation tonight. I have the pleasure of introducing our guest speaker tonight. Dr. Bhanu Prasad is an amazing nephrologist who trained in the tropical paradise of India for his Bachelor's of Medicine, did internal medicine and nephrology in the UK, moved to Canada as a very international citizen, currently practicing as a staff nephrologist with the Regina General Hospital. In 2018, awarded with the Physician of the Year by the Saskatchewan Medical Association, which is no surprise, currently an Associate Professor with the University of Saskatchewan. He's a community nephrologist, has been able to successfully merge clinically meaningful research with a busy clinical practice. In 2020, he received the Santé Research Excellence Award from the Saskatchewan Health Research Foundation. As if he wasn't busy enough, he has 50 publications thus far and is involved in a pan-Canadian research partnership. He has published on renal denervation, on the topic of hypertension, frailty, as well as fractures in CKD. Tonight, he will be bringing us state-of-the-art information about the Loin Pain Hematuria Syndrome. Without further ado, we'll turn it over to Dr. Bhanu Prasad.
Thank you, Dr. Baga, and thank you, Utsuka, for inviting me to this talk today. So this is my speaker disclosure slide. Of importance is that we've received some form of support from Medtronic, Utsuka, or Regina Hospital Foundation, and I am a co-author on Up to Date for LPHS. So what exactly is loin pain hematuria? So these patients are typically seen by urologists because they have pain arising from the kidney and they have hematuria. And so the urologists take them through cystoscopies and relevant imaging. And then after that, when there is no urological cause for blood and hematuria identified, it's a diagnosis of exclusion, and it's called loin pain hematuria syndrome. So while hematuria might bring some patients to nephrologists, but it is pain that bothers patients quite a lot. And it is not unusual for us to see patients who are in incredibly heavy doses of opiates, and a few of them are also receiving intrathecal administration of morphine. So by the time we see patients, they're often depressed, they're off work, they're disabled, and quite frankly, and I would say that they're broken, and few of them are contemplating suicide. So the patients typically present in one of these three scenarios. The first, and actually the most common, is that the patient has a obstructing renal stone and they present with flank pain and hematuria. And then the stone either passes spontaneously or is urologically removed. But even after the pain passes away, the patient keeps on coming back to the emergency room saying that they have a stone in the kidney, only for investigations to say otherwise. The second scenario is patients have spontaneous pain, unilaterally or bilaterally, and when they undergo investigations, there is blood and urine, but there is no protein, there is no white cells in, and there is no bacteria in microscopy. And so usually GPs will treat these patients a couple of times as a UTI, and there's no response, and they eventually get referred to a urologist. So third scenario, which is less common but does happen, is an athlete playing any form of sport starts to notice gross hematuria with pain, either unilaterally or bilaterally. Patients eventually quit playing the sport, but the pain persists, and again referred to urology, and investigations are negative. So please see that I've actually highlighted pain in bold and not necessarily focused on hematuria. And the reason is that pain is intense, and actually the first patient that we saw was contemplating a autonephrectomy when she came to see us. So pain sensation is due to direct stimulation of these sensory neurons. And in the kidney, there are these rapidly conducting, thinly myelinated A delta fibers and the more slowly conducting unmyelinated C fibers. And they go around the adventitia of the renal artery through the lumbar splanchnic nerves, and through T11 to L1 dorsal rami through to the spinal cord, and from there they go to the thalamus, and from there to the cortex. So I think it was clear from the very beginning that there was a lot of pressure on urologists to somehow interrupt these pain pathways. And so the initial literature on LPHS for pain relief is predominantly urology and surgery driven. And when the pain pathways were interrupted closer to the spinal cord, and they also ended up interrupting pain pathways or other sensory input and coming from other parts of the body, and often interrupting these pain pathways, led to side effects such as incontinence, sexual dysfunction, hyperhidrosis, autonomic dysfunction, and so on. So when attempts were made to interrupt surgically the pain pathways closer to the kidney, then the response wasn't as great, and pain often recurred. So patients either chose to have a nephrectomy, and there are at least 3 recorded cases where patients had bilateral nephrectomy rather than live with loin pain. But as a nephron-sparing procedure, autotransplantation was pioneered by, I think it's the first one was in 1983, and this was a complete transection. So you take the renal artery, renal vein, along with the nerve supply that comes around it, and then you put the kidney into an alternative site close to the external iliac artery. I think it's important to document with autotransplant is that even under the best surgical hands, it's a 7 to 8 hour procedure. There's a 5 to 7 post-operative stay in the hospital. These patients are not uremic, so they don't have platelet dysfunction. So when our patients undergo kidney transplant, the platelet dysfunction saves them for intra-arterial thrombosis. So these patients have a higher risk of intra-arterial thrombosis. So a 7 to 8 hour procedure with a 5 to 7 day post-operative stay. So this was your best option really for pain relief. So then came around catheter-based percutaneous minimally invasive renal denervation. And so kudos to people from Baker's Institute, Murray Esler, and Marcus Schlake, who actually pioneered this procedure in patients with hypertension. And I think this technique takes advantage of the fact that between the kidney and the aorta, these nerves that are traveling alongside it, whether there's afferent or efferent or ascending or descending nerves, whichever way you call it, they're actually embedded within the renal artery. So they are in the adventitia of the renal artery. And so that allows, catheter-based procedures to be successful. And so in this particular slide, as you can see, a radiologist has entered through the femoral artery and makes its way towards the renal artery. And this is the initial first generation Medtronic catheter, which is unipolar. It's just there's only one lead here. There's only one electrode. And through the electrode, a radio frequency energy would be released. And then the radiologist will then turn it around, manually, circumferentially, and then take it to another site. And then again, release of energy, and then again, release of energy, and then 4 times. And at best, even if you look at the first 2 Simplicity hypertension trials, the maximum amount of ablations were 6, and the mean ablations were 4. And all of these ablations were given in the proximal part of the renal artery. Well, we all know what happened with the hypertension studies when Simplicity 3 came out, and it was clear that a lot of people really did not get a great response to renal denervation, especially in the randomized, and when the patients were randomized. Then there was a lot of interest in neural innervation around the renal arteries. And so this is data from 25 autopsy subjects. And in this particular slide, you can see that even though proximally the nerve bundles are present, but they're actually quite distributed. So they're distributed right along. So there's distribution away and there's distribution closer to the lumen. But as you come more distal or come closer to the kidney, they're more tightly packed closer to the lumen. And so if you are going to denervate, I think you're going to get more bang for the buck closer to the kidney, then away from the kidney, which is what the initial 2 Simplicity trials did. So we were doing a separate kind of hypertension, CKD, stage 3, stage 4, looking at central blood pressures at the same time as Simplicity studies were coming out. So we were aware of the challenges that were going on at that point. And so we decided to learn from the challenges that hypertension studies faced. And so, and also technology improved. This was a single electrode. So eventually we had 6 different electrodes from Boston Scientific on a balloon mounted catheter. And now Medtronic has come up with a separate spiral catheter, which is, you know, longitudinally and circumferentially, you can get a good opposition. It's also important to say that at least 10% of patients have early branching of the renal arteries. And so the distal renal arteries, the branched renal arteries also have similar neural innervation, so interrupting nerve pathways in the branches and the accessory renal arteries is also important. So all the studies were with the Boston Scientific, and this is, as you can see, that this is a balloon mounted 6 different electrodes, bipolar system, 30-second energy release. So you give about 6 points of energy release, and hopefully we would get something like this. So we tried to get about 16 to 24 ablations on each side. So this was the first paper that came out it's a case report of 4 patients. The first patient that actually came to us was basically going to have a nephrectomy, and Dr. Francisco Garcia, a urology colleague and current co-researcher, sent the patient over, said, you guys are doing this for hypertension, why don't you do it for LPHS? And from hypertension studies, the response to RDN is quite variable, and it sometimes takes a little bit of time for pain relief to take place. Sorry, for hypertension to come down. In patients, it does come down. But we were actually absolutely surprised when the very first patient who had been on some form of pain relief for at least 13 years was completely pain-free as she came back from the radiology suite and remained pain-free for at least 12 months. So we then ended up doing 3 more patients and then published in the AJKD. And then subsequently, we did a bigger 12-patient study. You know, we did 16 to 24 ablations. We learned from all the mistakes that were made in the hypertension studies. When denervation happens in hypertension patients, you can get away with deep sedation. You really don't need any general anesthesia. But we found that patients with LPHS, we can do that. They needed GA. Otherwise, they were, you know, literally trying to jump out of the radiology suite. Even though patients had unilateral pain, we made sure that we gave bilateral denervation, because eventually at some point in time, unilateral pain becomes bilateral pain. And our results were quite staggering, really. So this is a McGill pain score. The maximum score is 78. Baseline for ours 38.5. And 6 months later, the pain was down to 2. As the pain improved, mood improved, and you can see from 3 all the way down to 1. And people were no longer disabled. They were going back to work, part-time, full-time. And some of the patients working as social workers, radiographers, phlebotomists ended up going back to full-time work. And as you can see, the quality of life certainly improved. And if you look at all the self-reported parameters from vitality to mental health, you look at the p-values here, there was an incredible improvement from baseline to end of 6 months. So there's always a small proportion of physicians that, you know, look at LPHS and say, well, there's, you know, strong psychological overtones. You know, this might be a somatoform disorder. People love drug seeking, and they're putting up these symptoms to say that, you know, they have something like this, and you guys call them LPHS, and you do this, and you offer them incredible amount of opiates. But I hope that people are going to look at this study results of ours, and we hope that, you know, that our observation lends support to the idea that LPHS has a true biological basis. And if there is anything like somatoform, it's probably superimposed. But the patient knew what we were doing, and we knew what we were doing. So So we were aware of the challenges that studies like this do. So especially, this is Saskatchewan, and this is ground zero for multiple sclerosis. So when people had venoplasty for multiple sclerosis and were randomized to a sham, there was no difference. Again, hypertension, again, is a great thing, a great study for denervation, and then, vertebroplasty for wedge compression fractures, percutaneous laser, myocardial revascularization, intra-articular injection of course, so you can see a lot of these things which actually made sense. The patients knew what we were doing, really didn't want the same kind of results when they were randomized. So we went ahead and then did a feasibility study for a randomized control trial. And so we took 10 patients, 10 new patients, and then because this time we were trying the Medtronic Simplicity RDN system. So we had 3 rule-ins, so 3 + 10. So 5 underwent renal denervation and 5 underwent sham. So we followed them for 6 months now. And so on the crossover has started. We would have had results of the crossover if it wasn't for the delay due to COVID and all non-essential procedures in the hospital are currently being put on hold. So otherwise, I would have given you a little bit more. I can't share results, but I can say that the results have been to our expectations at this point. So this, and once we do the feasibility, I hope we will carry on to do a bigger multi-center randomized control trial. So why do patients really have loin pain and hematuria remains the question. And we didn't focus on this initially because we were so focused on pain relief, but the more we started to see patients, the more we started taking interest in LPHS as a total rather than just pain relief. So as nephrologists, when we are looking at a patient, we'll do a detailed case history, we'll do family history, we'll do radiological investigations, serological investigations, and we don't get an answer. We often go into a kidney biopsy. And so that's what we did. We went ahead and we did a kidney biopsy on 14 patients. We got baseline data. And then we had Dr. Dukahaki, who's our pathologist in Saskatchewan, as a single pathologist, look at all the studies, so there was no variation in how the interpretation took place. And these are the results. This is unpublished data yet. We haven't published this. We're waiting for some proteomics information to become available, but I'm going to share something. So this history taking is a lot different to the history taking that we as nephrologists do. We have to ask about concurrent pain disorders, things like endometriosis, migraine, history of stones, obviously. And there's a strong overlap of patients with fibromyalgia and chronic fatigue syndrome. And there's a strong overlap with anxiety and mood and so on. So we did that history, and in a certain proportion of patients did have all of that. And there was also a strong family history of mood disorders and chronic fatigue syndrome and so on. So I think this is interesting. We really haven't put it all together, but this is some of the initial data that came out. With regards to the biopsies itself, hematuria, really when you're talking about hematuria, we're looking at electron microscopy evidence of basement membrane. And so we looked at, so the pathologist looked at basement membrane as per the paper that was published by T-Bosch in NEJM in 1989. I think that's the gold standard when you look at some of these studies and look at basement membrane. So a lot of our patients had lower or thinner basement membrane, but really did not meet the criteria for thin basement membrane nephropathy. So we have 14 patients with hematuria. Some of them have overt hematuria, and your basement membrane really does not meet the criteria for a thin basement membrane. So there was a paper by Manuel Praga in '98 in Kidney International, and they said, well, maybe they had a lot of microcrystals like uric acid crystals, oxalate crystals. And they said, well, they lead to blockage of the urine flow and this ultrafiltrate leak and so on. But we never saw in our case series, there was no microcrystals. And there's always, if you look at this biopsy data, there's always this fascination with complements, the C3 staining. And there's C3 staining in the arterioles. And the question then becomes is, what does C3 by itself in the arterioles really mean? There is no proliferation, there is no deposit formation. So what is C3 actually telling you? That's something that we fail to grasp. And then there's endothelial injury and ischemic wrinkling. There's always this thing about somehow patients have some form of vasoconstriction going to the kidney. And so even though vasoconstriction hasn't been proven consistently, but there's always the theory that this renal migraine equivalent going on. Then does this endothelial injury and ischemic wrinkling fit with that? And what do these deposits of fibrin tactoid mean? So are these little clues that are going to tell us what the diagnosis is, or are these just red herrings? And so to compare this, we went and compared our biopsies with 0R biopsies pre-transplant. And this is a paper from Switzerland going back to 91. And you can see that 74% of the patients had these non-specific deposits, and then 44% had intimal fibrosis. This is patient just about to give a kidney to their loved ones and had these kind of changes and not showing up in any of the renal biomarkers, perfect GFR, no proteinuria, no hematuria. And for patients to be giving a kidney, there should be no hypertension or diabetes. So, so it's clear that a lot of changes happen in our kidneys that show up histologically, but do not show up in our biomarkers. But clearly there was no pain or hematuria in any of these patients. And the same thing at 84, more recent study from India. Again, 50% of patients had normal histology, but there was also some chronic changes in some of the others. So what is the current hypothesis? And this is a paper by Lee Hebert from Ohio. I think a lot of data on LPHS comes from his team. And the first, so this is a kidney in a healthy individual. And so as you can see that there is no hematuria coming in here, but in a patient with LPHS, there is hematuria. For whatever reason, there is hematuria. And so Lee Hebert and his colleagues, and subsequently accepted by a lot of other groups, was that somehow this blocks the tubule. So what happens is that this ultrafiltrate starts to leak into the interstitium. And then once this ultrafiltrate leaks into the interstitium, it goes in and then it stretches the capsule. And the capsule is filled with nerve fibers, that's filled with sensory receptors. And then automatically you get pain. And so that's the current hypothesis. We don't believe that's the case, or we don't believe that's the case in 100% of the patients, but that's the current hypothesis. But the bottom line is a red cell has to make its way into the tubule. And for a red cell to make its way into the tubule, it has to cross 3 layers. I mean, there's obviously an fenestrated endothelium with its associated glycocalyx, there's basement membrane, and then there is filtration slits formed by the interdigitating foot processes. And if you, there is data, and there's a recent European Renal Association meeting showed some interesting pictures on this topic, but red cells have been shown to traverse microscopic pores, holes, microscopic ruptures within the basement membrane, but not everybody ends up getting loin pain to the intensity of getting their kidney removed. So basically that's your basement membrane. And so if a red cell has to make its way, it has to make its way through this collagen network, it has to make its way through this laminin network, it has to make its way through these other 9 different basement membrane proteins that exist. So let's look at two conditions where blood cells actually make its way into the urine, and then see some of the developments that have taken place in these 2 particular conditions. So let's say these 2 are 30-year-old men, and then one of them has sensory neural deafness, lenticonus, proteinuria, hematuria, and an abnormal filtration rate. And then on biopsy, they have a description of thick basement membrane, and they have some lamellations. And we call this combination, this constellation of signs and symptoms, as we call them, Alport syndrome. And then you compare that with with another person of the same age group, microscopic hematuria, no proteinuria, preserved filtration rate, and the biopsy shows a thin basement membrane. And we call this, and because this one has got a good prognosis and this one's got a terrible prognosis. But realistically, these two have the same challenges. They have mutations in genes that impact collagen, either A4, A3, or A5. And so in the recent 2015 International Workshop on Alport syndrome, it was proposed that Alports and benign familial hematuria, or thin basement membrane, be classified as a collagen 4 related renal disease. So realistically, both these diseases have mutations in collagen. And as a result of these mutations, there's impact on assembly, there's an impact on synthesis, on deposition and function of collagen 4. So if our patients have hematuria, LPHS, then realistically, there has to be some form of a variant impacting one of these proteins that are part of the basement membrane or endothelium or the slit processes. So the next one is pain. And pain really, so these pain fibers are present throughout the kidney, and they really have to be stimulated for pain sensation to go through. So nociceptors, detect signals from damaged tissue or also respond to chemicals that are released from damaged tissue. So from here, they go to the dorsal horn. From there, it crosses off to the contralateral side and then go to the thalamus through the anterior spinal thalamic tract. And one of the things that we noticed in all our patients who underwent denervation, and probably closer to 28 odd patients, is that every single one of them complained of intense amount of pain at the site where the radiologist went in through the femoral artery. Now, people go through femoral artery and we see 75-year-olds undergo a coronary angiogram and then are walking immediately after. But patients with LPHS really couldn't, and they had intense amount of pain. So clearly, we thought maybe they have amplification of pain pathways or something. And they also have other things like endometriosis where they have incredible amount of pain. So it's possible that either one of the genes associated with transduction or modulation or conduction, there might be a variant, and there might be some upregulation of some of these pain pathways. So what are we planning to do? I think we're looking at a whole genome sequencing. So we're going to do genome analysis, transcriptome analysis, and proteomic analysis. And so we have our 14 patients with LPHS, and we have taken blood from them, we have taken urine from them, and we have taken kidney biopsies from them. And then we have isolated hematuria, 14 patients, and we have taken blood and urine. We debated whether to put them through a kidney biopsy. It gets tricky when patients don't have proteinuria or have perfectly normal kidney function, to put them through a kidney biopsy with the associated risk of bleeding. So we didn't take a kidney biopsy from them, but we did take blood and urine from them. And so the plan is to see if there's any variants that are engaged that lead to endothelial proteins or glycocalyx or basement membrane or porocytes, and these are the proteins on this side. And then look at if there is any variance in voltage-gated channels or pain amplification genes or opioid receptors and so on. So hopefully, we're just waiting for some of these contracts with labs to take place before we start doing some of this analysis. So eventually we'll have to come to this to say, well, are these three the same, right? Are these three people the same? As they all three are called LPHS. Is LPHS like FSGS? Is it just like a useful descriptor of shared phenotypic features, or is it like are they a collection of etiologically distinct entities? And to do that, we'll have to work a little bit harder at this. We'll have to get a detailed phenotype assessment. We have biopsy data, and now we'll have to add genome data, and then we'll have to add transcriptome data, and then we'll have to add some proteomic data, and then get some better understanding of each and every patient, and then come up with a better answer because I think our patients deserve a lot better. And so moving forward, we would like to do the feasibility study. We'd like to follow up with a multi-center randomized control trial. We're looking for other sites who might be interested in things like an RCT in the near future. An attempt will be made to classify loin pain hematuria based on clinical and molecular criteria, rather than relying solely on histological and clinical traits. I hope, publications by our group and other groups will help administrators allow RDN in their institutions for pain relief, and then hopefully better biomarkers. So with that, I would like to thank, so we have a great team. Dr. Jafari is our clinical lead. Aditi Sharma joined, and she's leading the genetics part, and they're both in-house here. Goel has done the most renal denervations on planet Earth. Dr. Garcia is a urologist who, along with myself, we go through all the patients. So he looks from the urological standpoint, then I look at from and then Dr. Babu, professor, and he's the proteomics expert. I'm glad to have Dr. Grant from McGill University, who's a pain researcher. Sarah Liskowitz joined us, and she has an interest in pain and addiction. And then Xian Wei with the UFS, who's going to do all our genetics work. And so we're probably supported by Hospitals Regina Foundation, a generous grant. Medtronic and Otsuka have recently given us some grants. We also have grants from Saskatchewan Health Research Foundation and University of Saskatchewan Conrad. And then we have partnerships with a few people. So thank you so much, and I'm open for questions.
Thank you. I'd like to just begin with a genuine appreciation to Dr. Prasad for an elegant presentation once again. Thank you to Otsuka for helping us organizing this. I guess if there are any I'll just open it up first to see if there's any questions in the audience that would like to unmute and ask their question. I think there's a Dr. Mona that wanted to ask a question. Would you like to ask your question?
So as I realized that one of my patients is suffering from the syndrome, fibromyalgia, terrible loin pain, hematuria, she had a kidney biopsy. The result was then, what would be the next step? I'm in the suburb of Montreal. Thank you for your, okay. So, well, unfortunately, I think the patient will benefit from denervation. At least there will be a 6 to 12 month complete resolution of her pain symptoms. In the absence of it, I think it's sending people to pain clinics and treating them with conventional pain medications for now. We're always looking for patients for the larger RCT, and you're welcome to send these patients to us, and we can put them in a larger. So it's a 64 patient RCT that's going to happen in the near future, and so we can connect after this meeting, and then we can have a conversation around it.
There's a Dr. Kishore Vishwanathan who'd like to ask a question.
Thank you. Bhanu, thank you very much for the invitation today. I am really delighted not only to hear about your experience, but I'll just mention to everyone else on the call, I'm a urologist in Saskatoon. I'm 2.5 hours away from Dr. Prasad, so this is a very practical exercise for me. Especially today, I just operated on a lady who fit exactly your description. I did a ureteroscopy on her. She has chronic flank pain, but she has medullary sponge kidney. So I want to ask about, is that appropriate? She has chronic flank pain. She has contemplated suicide. She's on high doses of opioids. What do you think about that situation?
Yeah, so Kishore, she doesn't fall under the category of Loin Pain Hematuria Syndrome because it's a diagnosis of exclusion. There's reasons for pain, but she will get excellent pain relief. And one of the things that we were thinking as part of our larger RCT is to include patients with polycystic kidney disease and some of the cases that you mentioned as part of a larger group, because if we are trying to achieve pain relief, and I think we might have to expand the group to get the numbers, but she will definitely benefit from denervation.
Thank you again. I enjoyed it, and I think you've given my patients some hope.
While we're seeing if anyone else has any questions, one of the questions that came up privately was, can we make a diagnosis without hematuria?
Yes, I think sometimes hematuria is intermittent, and and sometimes people have hematuria when they have these exacerbations of pain. So most people will have this baseline 3 out of 10, 4 out of 10 pain, and then they have this intensification of pain, and at that time they have hematuria. So realistically, when they have this baseline pain, they have no hematuria. Now, how is that different from differences? So there's a potpourri of patients that come into the category. So, but I think if the answer is yes, they can have no hematuria at that point intermittently, but they will have pain hematuria at different time points.
All right, another question that came up was, with respect to renal denervation therapy, we've talked about it in the context of this condition, loin pain hematuria. What is your experience with its benefits or lack of benefit in other conditions?
So there's a group from, his name is Peter Blankenstein. I think he published on patients so they're from Amsterdam. So polycystic kidney disease, I think they showed some improvement there. Unfortunately, they used the first generation Medtronic technology, which was a single, unipolar single electrode. So there were some challenges there. So I think if the pain's coming from the kidney, and we are sure that the pain's coming from the kidney, interrupting the pain pathways by RDN is easy. It's 45 minutes, and there's a 1 hour to 1.5 hour recovery time, because we put them through general anesthesia. Most of them are walking out in 4 hours time, compared to the surgical procedures that Kishore does. This is easy, and it doesn't cost much. And so I think, and then 6 to 12 months at least initially of opiate-free life. So I think there's a lot of upside to denervation. I for one believe that, we've looked at hypertension very carefully. We've been involved in hypertension, outside of the Medtronic, if you look at hypertension improvement, 3 out of 10 people will not benefit from denervation right off the bat, even with the surgical procedures where they were surgically interrupting the pathways. 3 out of 10 right off the bat will never get better. And the rest of them, they take their own sweet time for blood pressures to improve. With denervation, there's instantaneous pain relief. And I think that's something that we couldn't get over.
Excellent. A question from Dr. Francisco Garcia.
Hi, Bhanu.
Hi.
Not so much of a question, but just something to add, having assessed and looked at a lot of these patients. One thing that really helps in the diagnostics, I found anyways, are those patients who have a horrendous, terrible pain response to the nuclear medicine scans. So you give them a split function LASIK renogram, and they tell you horror stories of how much pain they have. Those ones tend to have a phenomenal benefit, I've seen, when they actually go through the denervation, which is certainly really impressive. So I don't know, it's a little tidbit. I'm wondering if there's maybe some way to interpret that into the diagnostic criteria when you're categorizing. That might be something that we should be looking at as well as a clinical feature. But I know the one thing that I was very concerned about, you might remember we were talking about this at the beginning, particularly with repeated denervations, was the risk of renal artery stenosis. And you might remember, like, we had a few of those patients at the beginning, had 2 or 3 denervations within a couple of years. And I was paranoid, and we kept scanning them, and I'm happy to report that none of them ever really developed any renal artery stenosis. So, I think from a nephrological consideration point of view, that's something I can understand being a worry. But so far with these devices, there doesn't seem to be any significant damage to the intima that's causing, that could cause that as a long-term problem. So there may be some real benefit with repeated denervations if it's necessary, if we're only getting short-term benefits there. So just another sort of point to throw out there as a potential benefits for these patients. And I know somebody's going to think about, well, what about stenosis down the road? doesn't seem to happen. And I did regrettably have to take a kidney out for one lady who did have 3 treatments, but when we even looked at the artery on that one, it looked fine. So so it's kind of really interesting to see that despite multiple treatments, there was really no significant damage to the intima, to the artery, and it wasn't compromised in any significant way despite multiple treatments.
Thank you, Francisco.
Awesome. Another follow-up question from Dr. Mona Ben Emrad. Do you have any colleagues doing this in Montreal or a Montreal expert that you could connect Montreal physicians to?
No, not that I'm aware of.
Okay.
I think Paul Sohi in New Brunswick might be doing them, but we don't know for sure yet. So I think so that might be a little bit closer.
Okay. If there aren't any more questions or comments from anyone in the crowd, we'll once again thank Dr. Prasad for this wonderful evening spotlighting Loin Pain Hematuria Syndrome and renal denervation. And if anyone has any colleagues interested in participating in research trials, he's the gentleman to reach out to. So thanks again for the support from Otsuka. Hope everyone has a great rest of their evening, a great Christmas season, New Year's, and enjoy the night. Thank you for everyone.
Thank you, Amit. Thank you, Otsuka. Thank you so much.